So, like Mena said, my name is Amanda, and I'm a radiation therapist at the University Hospital of Zurich in Switzerland. And the focus of my talk today will be about how you can use SGRT not only to eliminate tattoos, but also to reduce setup time for SBRT lung treatments. So our current system, or our current situation, is actually very similar to what you were talking about at your center. We have 3 LINACs, but only 2 SGRT devices. So we've had one on our Varian Edge for about 4 years, and 2 years ago we got an additional LINART system on our Trilogy. So we use SGRT for all our breast treatments, both free breathing and DIBH. We've stopped drawing skin marks on our breast patients, and we wanted to set a goal for ourselves to go tattoo-less. So the first group that we picked is actually SBRT lung treatments. And we did this because it's a smaller patient population that we could easily analyze. And we set ourselves also some additional objectives. So not only the eliminating of tattoos, but also to see if we could set these patients up using SGRT in a reliable way. So for us, that means that we see a shift on our cone beam of less than 3 centimeters, because if we see a shift larger than this at our center, that means you have to repeat the cone beam. So that would be additional dose to our patients and also rather inefficient. We also wanted to look at if setting patients up with the LINART increase our efficiency, so decreases our setup time. And additionally, we have a unique situation at our clinic in that we have a Varian RPM solution on our planning CT. So we want to do our 4D CT planning CTs with the Varian RPM solution, but then gate our patients on the treatment with the LINART. So we wanted to understand the relationship between these two systems to ensure that what you do at planning CT can be translated to what you want to do at treatment. So this is our standard workflow for lung SBRT patients at our clinic. These are our typical fractionations. And as I said, all our lung SBRT patients receive a 4D planning CT. Have a very typical setup like you see in the photo on the right here. So there's a vacuum bag that we form to the patient, and their arms are up out of the way on a wing board. They typically receive 3 tattoos, so a 3-point setup. We use these tattoos to set up the patient, and then we manually calculate the shift from these tattoos to the isocenter. Additionally, we then draw the isocenter with marker, and we put surgical tapes on top of these marks to ensure that they don't wash off over the additional treatment days. And this is our proposed workflow with SGRT, sorry. So we decided nothing would change at the time of CT, nothing changed for our planners and how we design our plans. But the big change is when patients come to treatment, they come into the bunker, they lie down on this vacuum bag that we have formed for them. We drive the table up under the gantry, and we immediately turn on our LINART. So the entire setup process is done based on what our LINART is telling us. And because we do a 4D planning CT, we've imported this average surface, and we move the table and roll the patient around until these deviations are as close to 0 as possible. And then because it's SBRT, we're always going to daily cone beam these patients. We perform a cone beam. We match a PTV in 6 degrees. We have a table that can achieve all 6 degrees of rotation, so we apply all the matches that we see. And similar to also what they were talking about in Groningen, we take our cone beam CT as gold standard. So once we have shifted our patients, we capture a new reference, and you can see that all these deviations go nicely to 0. And then you know, definitely 100% for sure, any deviation you see from this point on is a patient movement after you've verified their position. So all our lung SBRT patients are treated either on our Varian Edge, where we have an SGRT device, or on our TrueBeam, where we don't. So for us, it was quite easy to split our patients into 2 groups. So we did 10 patients to each group, 10 of which were set up with the proposed workflow using a LINART, and 10 with the traditional workflow of tattoo and skin marks. And this is the kind of data that you can pull out from the LINART after the fact. So anything that you want to do for your research or statistics, you can really find it retrospectively in the system. And so this is what a typical setup of an SBRT patient looks like. So you can actually see at the beginning, we turned the system on when we were still quite far from the ISO center. We do an initial setup of the patient. And then this area here where it looks like nothing is happening is actually our cone beam CT. And then you see this movement at the ends, and that's not a patient movement, that's actually the shift we've applied from our cone beam CT. And then we take a new reference, and any motion that happens after that is in a separate file. Like I said, there's really no hiding from the system. You see everything. So this is an example of a patient where we've had to move the treatment couch to the center for the purpose of the cone beam CT. So you actually see this is initial setup. This is us moving the couch to get the gantry underneath. This area where the patient is consistently 4 centimeters off laterally is actually the table that's been centered. So even if you center the table, the system continues to monitor and observe your patient. And then again, at the end, you see this deviation, which is our 6 degrees match that we've applied. And so what we wanted to do was to just investigate how accurate the setup that we were doing with the SGRT is compared to our cone beam. And we didn't want to just pick a random point on this line because maybe you catch the patient in a breath. So what we actually did was we averaged the 8-second or 10 seconds previous to cone beam. We took an average of this position and compared it to our cone beam. And this is what we got. So like I said, the goal we set for ourselves was 3 centimeters. As you can see, it's substantially smaller. So the average difference, average absolute difference between our SGRT setup and our cone beam for our lung SBRT patients is in the range of 2 to 3 millimeters. And you see for our tattoo and skin mark group, it's about double. So we're still talking in the range of 6 millimeters. But I think what's important to look at is our standard deviations. So they're quite tight. There's a very good correlation in the SGRT group, and you see this spread of data from about 1 to 2 centimeters when you're using these tattoos and skin marks. And if you're someone like me who needs graphs, this is the same information just in a graph or in a chart. So like I was saying, you really see the spread of the data, all these outliers, specifically in the tattoo and skin mark group that you don't see in the patients that were set up using SGRT. Also, if we're talking in terms of absolute shifts that were applied in the SGRT group, there wasn't a single fraction that had a shift larger than 1 centimeter, but 12 of the fractions had a shift of larger than 1 centimeter in the tattoo and skin mark group. And additionally, like I said before, these outliers up here are above this 3 centimeter line, so those are patients that would have been additionally cone beamed and had additional setup time. And some of these shifts are quite large. We were, for a short while, rather alarmed. So we wanted to investigate where these came from. And this is what we came up with. So I think as a therapist, everyone has stood in the room at some point and tried to calculate a shift and then decided you had to write it down. So I think one of the things that could result in a larger shift on your cone beam, or a setup error, if you will, is miscalculated shifts. At our center, we also tend to use saved table values for the table height. This could also maybe not be the most accurate approach. Also, as we were talking about before, the patients can lose the marks. Once they start applying creams, the marks can slide, they can move. And the nice thing is that all 4 of these sources of potential error are basically, essentially, totally eliminated when you set up with an SGRT device, because you're no longer manually calculating shifts in the room, you're not looking at saved table values, and there's no marks that can disappear or move. So like I said, the next thing we wanted to do was to say, is this efficient for us? Is this helping us? Is this saving us time? So because we looked at both groups retrospectively, so that it was fair 1-to-1, what we did was we measured the time from when we opened the plan on the treatment console to the time of cone beam. So this does include the patient coming into the room, maybe a little chit chat, but it's fair and it's the same for both groups. And what you see is that the SGRT group is on average about 3 minutes faster. But I think what's also nice, because our workflow was that the patient lies down, we drive the table up, which takes about 10 seconds, and you already start the monitoring. You can see exactly for the time from when you turned the system on to the time of cone beam. So that's actually the time that you were moving the table and pulling the patient around in the room. So you can see that, so 24 of our 41 fractions, so more than half, we only had a setup time of 1 to 2 minutes, which is very efficient. And the last thing I want to talk to you about is how the situation is at our clinic. So like I said, we do a 4D planning CT. We treat with an ITV concept. So this means what we would typically do is at the time of CT, during our 4D planning CT, we get a curve from the RPM system that looks like this. And we wanted to understand, if I see a curve like this at CT, what do I put here for my thresholds at the time of treatment to ensure that what you're planning is actually what you're delivering? So in order to do that, we had 10 volunteers. We had them lie in our treatment table, and we have the ability to simultaneously record both an RPM curve and monitor them with the AlignRT system. We did have an additional volunteer who we asked to cough, just because we wanted to see how both the systems reacted to large motion. And like I said, this isn't about which system is better. I think everyone in this room, since you're all here at this SGRT talk, can agree that we want to kind of get away from the surrogate that might have daily variability and look at more actually what the patient is doing and this ROI directly on the patient's skin. So it's just about understanding this relationship between the two. And this is the kind of data you can pull out. So finding the RPM data was a little bit harder, but you can get it out of your LINAC. And the RPM from Variant actually also records the longitudinal and the lateral motion, which I didn't know. And you can only gate on the vertical, but the data is there if you want to look at it. So I think what's important to take from here is that both the systems see a very similar curve for the same patient. You see the same frequency of the breath, the general shape of the curve is the same. What's different really is the amplitude, so the gross motion that each system sees, which is something that we were expecting since there is a small degree of averaging when you look at an ROI. But what we wanted to see, or what we hoped to see, is that when my RPM says so much, so 4 millimeters, what can I do with my AlignRT? That there was a nice clear ratio between the two. And in the longitudinal motion, this is mostly the case, but in the vertical, not so much. And I think this really has to do with how patients breathe. So we all know that patients breathe a little differently. Some patients breathe into their chest a little more, some are belly breathers. But what you see here is in terms of a cough, so if there ever was a really large movement, both systems really agree. And we actually had a patient that took their arm down during the treatment and the AlignRT shut off. And because you have such a quick frame rate, I do think that the reaction time from the system is much quicker than someone stopping the beam with their hands. So what we concluded is that they are not one-to-one. It's probably to do with this ROI, but we don't want to change our ROI because this ROI is clinically relevant for us. And so our next step would be to try and identify at CT if a patient is a chest breather or a belly breather, and then apply the relative thresholds based on this. So I talked about a lot of things today, but the take-home message is really that for us, AlignRT can definitely be used in SBRT lung patients to position the patient without need for any additional tattoos or any marks on the patient's skin, even in the presence of setup devices, so this vacuum bag that we've made for the patient. And AlignRT can also be used to monitor the patient during the treatment to give confidence about target irradiation and additional confidence about if your patient has really moved. And that the AlignRT also increased our efficiency in patient setup. So I just want to thank my team at the University Hospital of Zurich, especially my physicist, Mariangela Zamberlini. This is as much her talk as it is mine. And thanks for your attention.
Great presentation, thank you. Do you find difficulties in monitoring male patients with Align RT because the surface is quite flat?
Not particularly. We do use an extended ROI, like the one you saw, and I think because it comes down the sides, it does detect this motion of the ribs. And we also, how you were saying, we don't generally have problems with the camera being blocked because we do have this nice ROI that wraps around both sides. And even with such a large ROI, the frame rate is still about 3, so it's quite high.
Hi, it's probably a question for all three presenters, but in terms of not permanently tattooing patients, we come up against problems with clinicians who worry about retreatment and knowing where the first sort of radiotherapy treatment's been delivered. Have you come across, any of you, that sort of reaction from clinicians?
No, and I have to say, in Zurich, we do a lot of retreating. I would say, as a Canadian trained person, I think that we tend to retreat a lot more in Switzerland. They're happy with the increased accuracy and the new SBRT techniques, with the confidence to be able to retreat patients. And generally, now that everything is planned in Eclipse, I think if you're talking about really old setups that you're taking from an Impax or something where you need the ISO center and to recreate the fields yourself, this maybe could be a problem, but once you can import the plans into Eclipse and directly compare them on the same CT, I think this is no longer an issue.
Thank you.